unfolding falciform folds and their consequences. To touch or not to touch. We have no financial interest to disclose. Falciform folds are congenital tractional retinal folds due to strong tractional retinal forces and hyperextensibility of retina. This results in temporal dragging of macula and vision loss. Occasionally it is associated with familial exudative vitreoretinopathy. Even the hardcore VA surgeons are often reluctant to touch these cases. This video demonstrates a novel innovative surgical technique to remove both pre-retinal and sub-retinal adhesions to unfold these folds. 43-year-old male presented with dimness of vision in right eye since childhood. In left eye it was for last 1 month. In right eye there was a falciform shaped fold extending from the disc towards temporal periphery with temporal dragging of macula and a small fundal coloboma just temporal to the optic disc. In left eye there was fovea on temporal retinal detachment. The plan of surgery in right eye was vitrectomy with ILM pilling with injection of balanced salt solution subretinally and sulfur hexafluoride gas tamponade. In left eye vitreoretinal surgery with silicone oil tamponade to settle retinal detachment. 25 gauge vitrectomy was done in right eye with removal of all pre-retinal vitreous bands and tractions. ILM was stained with brilliant blue G dye and peeled in a patchy manner as it was very stickily adhered to the underlying retina. ILM peeling was also carried out over and around the falciform fold. Diamond dusted membrane scraper was used to do gentle rubbing over the wrinkled macula to flatten the fold. Then a 38 gauge polytip needle attached with a VFC syringe filled with balanced salt solution was used to inject BSS subretinally. It formed blebs at multiple locations around the falciform fold. The subretinal BSS would stretch the subretinal space to remove subretinal adhesions in this long-standing fold. Finally, presence of any peripheral adhesions was checked again and air fluid exchange was completed. After 3 months of surgery, the fold at the macular area was narrowed down and almost flattened. Vision improved to 20/80. Left eye retinal detachment was treated with vitrectomy, PVD induction, internal drainage, barraging all lattices and breaks, and silicone oil endotamponate. Post-operatively, final vision improved to 20/30 after removal of silicone oil in this eye. So much about the promising result, but my previous experience in a similar case was quite disappointing. Operated on a 11-year-old girl who presented with counting finger close to face vision in right eye and an elevated temporal falciform fold. Her left eye was absolutely normal with BCVA 20/20. The same surgical steps were performed: vitrectomy with ILM pilling and submacular BSS injection and SF6 gas tamponade. But she developed macular hole with retinal detachment after 2 weeks. I had to re-peel the ILM to use free ILM flap to close the macular hole under silicone oil. Finally, patient achieved 20/80 BCVA after phacoemulsification with silicone oil removal and complete flattening of falciform fold with attached retina. A third challenge presented with a 33-year-old one-eyed female patient. Her vision in right eye came down to accurate PL and PR levels for last 5 days. Her right eye cataract was advanced. A combined phacoemulsification IOL implantation along with vitrectomy was done. There was familial exudative vitreoretinopathy with temporal falciform fold with total retinal detachment and mild vitreous hemorrhage. Vitrectomy was going on uneventfully. Suddenly the detachment became bullous. I realized my infusion cannula tip had gone sub-retinally. I ensured that the infusion cannula tip remained inside the vitreous cavity. Did a small retinotomy superiorly to decrease the bullous nature of retinal detachment. Removed triamcinolone stained vitreous schisis membranes. Injected heavy fluid PFCL and removed all vitreous. Peripheral circumferential retinectomy was done for redundant retinal fold and air fluid exchange started. Injected more PFCL beyond the retinectomy margin to flatten the retina. Then I used a Flex loop to unfold the residual retinal fold as much as possible. Finally, laser done around the retinectomy margin and all around periphery. PFCL removed and silicone oil injected. Post-operatively, the retina was attached and flattened. After silicone oil removal, patient gained 2200 base corrected visual acuity. So to unfold the falciform fold, things we should remember. There are both long-standing pre- and sub-retinal adhesions. Pre-retinal adhesions can be released by vitrectomy, adhesion removal, ILM pilling as well as mechanical stretching by Thanos scraper or Flex loop. For sub-retinal adhesions, inducing sub-retinal stretching by injecting BSS subretinally, but it should be done away from fovea to avoid macular hole formation. Our innovative surgical approach in these extremely difficult cases may help to recover satisfactory vision. Thank you.